Morning, everyone. Welcome to the Department of Medicine Grand Rounds. Today we have a special guest, as you see on the board. But as we do every Thursday, we're going to celebrate a few people who have made a change in the way we think about medicine, biology, and life in general. So we're going to talk about three people who separated each other for about a century each. And we're going to start with Marcello Malpighi. Okay? And Marcello Malpighi died on this day back in 1694 at age 66. He was an Italian physician and biologist who was working on developing experimental methods to study living things. And in doing so, he founded the science of microscopic anatomy. Microscopic anatomy. And in fact, it was because of his work that microscopic anatomy became a prerequisite for later advances in embryology and in physiology and even in practical medicine. He followed the steps of William Harvey. So he studied the circulatory system and the respiratory systems. He developed these hierarchical systems about living things that were have been evolving throughout the years as we get better understanding of them. But he was one of the first scientists to carefully look at the anatomical structure of organs, including the lung and the kidney, and as it relates today, the skin. About 100 years later was the birth of a German physician called Johann Lucas Schönlein. He was born on this day, back in 1793. He established a medicine. He was trying to establish medicine as one of these natural sciences. But in doing so, he helped create the way today we teach our students. And he developed a little bit of what we understand today as the practice of clinical medicine. He was one of the first, if not the first, to use the microscope, urine analysis, and blood analysis to make a diagnosis. And you may have remembered this name because he was the one who coined the term hemophilia. And back in 1828, he was the first to describe purpura rheumatica, which today we call Schönlein's disease, and a couple of other more things. Move forward another 100 years. In 1899 was the birth on this day of Andrew Jackson, not the one you know, Andrew Jackson Moyer, M-O-Y-E-R. Andrew Jackson Moyer was an American microbiologist, and he was working in the U.S. Department of Agriculture. And at that time, he found a different way to mass produce penicillin. And in fact, because it was mass produced, many people ascribed that effort for the saving of many thousands of lives during World War II. Okay? So three people who were separated by 100 years who still impact the way we think about medicine and education and clinical practice today. And with that, I leave you with one of our top clinicians, Dr. Jeff Kalin, the head of dermatology, who's going to introduce our guest speaker of the day.
Okay, thanks, Jesse. So I have the privilege of welcoming Boris Lushniak, who is our speaker today. Boris hails from Chicago, where he grew up, was born and grew up. He then went to Northwestern with the Flex program, I think is what it was called in those days, which was a 6-year program where he entered immediately after high school. And he was on his way to become a family physician, which is what he actually did. But he took a little hiatus right after medical school and did a year getting his master's in public health. And that turned him on, and he finished his residency, and then he entered the one of the uniformed services, which is the public health service, and was initially stationed in Cincinnati, just up the road. He then eventually moved to Washington, where he became he was working for the CDC in Cincinnati. Cincinnati's branch is called NIOSH, and he moved to Washington to eventually become a deputy surgeon general, and then for a period of time, when they were attempting to reconfirm another surgeon general, he was the surgeon general. So he was the acting surgeon general for 18 months, I think. Is that right? And then subsequently last year, he decided to leave the uniformed services, public health service, and has been for the last 10 months the dean of the School of Public Health at the University of Maryland. And he's going to talk to us a bit about public health and how it relates to dermatology. And Boris, thank you for coming. I should tell you that Boris's presence here is being supported by our lectureship fund, and we'll have a plaque. His name has been added to our plaque, which is in our offices, but he's one of the Callan lecturers this year. So, Boris, welcome to Louisville.
Thank you so. Thank you. Thank you so much, Jeff. Thank you, Dr. Roman, for that kind introduction. So the next 45 minutes or so, I want to take you on a journey. And the journey may be a little less typical than you perhaps get here at Grand Rounds. What we're going to be delving into is really sort of my passion, both as a clinician, initially trained in family medicine, as a preventive medicine doc, trained in occupational medicine, and then ultimately trained in dermatology. But in that whole career path, my real passion has been public health, right? Looking at the idea of our patients being the population. Now, because this is being sponsored by the Division of Dermatology, obviously we're going to be using examples from the skin. But what I really want to walk away with today is the sense of the importance of prevention, the importance of wellness, the importance of us looking at population-based information as an important facet of the practice of medicine. So the usual disclosures: I don't have any relevant financial relationships, no off-label discussions, work supported now by the state of Maryland, and I spent 28 years in the federal system. I'm not referring to the federal prison system, I'm referring to being a government employee, both at the CDC, at the FDA, and at the Department of Health and Human Services within the Office of the U.S. Surgeon General, all the while being an officer in the U.S. Public Health Service Commission Corps. For the young people out there, medical students, residents, if you're looking for an exciting pathway, and this is a commercial, that's put out there, look at the Public Health Service as something that is a viable option for clinicians to be able to serve their nation. So, when we look at this whole public health view, let's look at it from the perspective as how does dermatology, or fill in your blank, right? If you're an internist, how does internal medicine fit into this whole idea of public health? If you're a specialist, if you're a cardiologist, how does that fit into public health? Really, the goal here is to look at us as individuals. No matter what you are, how do you fit into the whole public health model? Part of this is awareness, right, of the public health environment and our role as physicians. And my first sort of message to you will be the idea that we have to stay connected with what's going on in the world. And the concept here is public health updates, right? Besides being excellent clinicians, besides being those individuals who are out there taking care of patients, the reality is the environment around us needs to be looked at from that perspective, right? We need to know what's going on in the world. We'll also talk today about core public health functions, and the examples we'll use is skin cancer, looking at both surveillance, exposure, the regulations, the screening, and the national prevention priorities. And then we'll finish up, as you notice, the talk goes from policy, which is embedded within examples of skin cancer prevention, to pox. Because an important part of what I want to bring here as well is just reminders of those ugly things that potentially threaten us, and that includes the bio-threat agents that are out there. So when I look at public health updates of interest to the dermatologist or to the internist, as I mentioned, those of you not getting this on a regular basis, copy down or remember this web address, cdc.gov/MMWR. Right? MMWR is the Morbidity and Mortality Weekly Report. And the reason I'm asking you to subscribe to this, it used to come as a mailing to you. Nobody does mailings anymore, right? Everything is email oriented, and I know you get a ton of these things. But this is an example of one, and I'll describe even I as a public health person how I use this. These reports come in from the CDC, and they come in with the headlines. What's going on in the world right now in terms of a public health issue? And all I do is I scan the headlines. And if it's nothing that I'm interested in, if it's nothing that is pertinent, right, then I just delete the email. But embedded in that could be something very important. It could be in early stages of an outbreak. And I think we as clinicians need to be aware of what's going on out there, because the next patient you see may be part of this. So this is a way of environmental awareness, right? The concept that we have this ability. There's also CME options through the Morbidity and Mortality Weekly Report, and this is that primary voice for scientific publication of timely, reliable information on public health issues. These articles are brief and to the point. They go through peer review, but a very brief peer review. These will then later on be published, but this is what's going on, current state of affairs in public health. These are examples of things that are published there, right? So this is 2013, measles outbreaks, congenital rubella syndrome, secondary tertiary transmission of vaccinia. 2014, these are mostly pertinent to the dermatology world, but varicella vaccination coverage, notes from the field about varicella-associated death, global control and regional elimination of measles, Hansen's disease information. 15 and 16, clinical guidance came out for the smallpox vaccine, laboratory-acquired vaccinia, measles, Ebola, dengue, chikungunya, Zika. Right? This gives you a sense in, again, a very brief approach to information that can be utilized in your clinical world. So that's really lesson number one I'd like to pass on to you. Look at the MMWR, look at the information that the CDC is putting out there every single week. Now, phase two of all this. Let's talk public health. And this is actually my favorite definition of public health. Notice the year, 1920. C.A. Winslow was a microbiologist. And the sense here is that public health is both a science and an art. And it's about, as I teach my students now, about the 3 Ps. It's about preventing disease. It's about promoting health with the goal ultimately of prolonging life. Now we talk about not just prolonging life, but a quality of that life as well. Right? So we bring that in. But notice that public health in the latter part of this definition is all about what? A partnership. Right? It's not just the feds that are involved in public health. It's not just the CDC involved in public health. Right? This is all about informed choices of society, organizations, both public and private, communities and individuals. So from one respect, right, our common bond in this room is what? Chances are we're all in the healthcare professions. Right? You're the former chair of internal medicine. You come back for this meeting because you have a connectivity with this world. Right, with this medical world. But as individuals, we also have to realize that we provide that role of being role models, right, to the patients that we see. So part of your public health activity is what are you doing for your own health? Right? What are you doing so that the patients see that you, in fact, are the epitome of health? That's the first component of public health. It's part of the individual aspect, right, of our roles as public health practitioners. Certainly then as a community we get bigger, right? We as physicians, we within our specialty societies, look at population health as a key component of what we're doing, right? Part of what we do is that interaction, right? I truly am interested as to your blood pressure, right? I truly am interested about your blood glucose. That's what we do. That's what you're being trained to do right now. But ultimately, we also look at the idea of what's our community doing, right? What's the incidence of obesity in my community? What's the incidence of overweight, of hypertension, of cardiovascular? Am I involved in that? Am I playing a role in that? Now, the core public health functions are all about 3 major components, right? It's about assessing and monitoring. It's the whole issue of how do we measure what's going on, right? We use the term surveillance. It's not the spy versus spy surveillance. It's the sense is that we're out there looking. We're looking at numbers. We're monitoring what's going on in that community. But it's not enough just to measure things. It's not enough. What you have to be able to do in public health is take those measurements and ultimately do something about them. And we talk about the idea of policies, of changes in the way we do things, right? They're designed to solve identified local and national health problems and priorities. The third component of public health is assuring that our populations have access to the clinicians, have access to prevention activities, have access to health and wellness activities. A third key component within that. Now, the public health model, the approach that we look at from a public health perspective for all diseases, ultimately, and we're going to use skin cancer as an example shortly, is we start with surveillance. And really the question of surveillance is what? it asks a question. And the question is, what's the problem? Right? What's going on out there? Right? How big is this problem? What's its impact on my community? We then look at phase 2 of this public health model, risk factor identification. What's the cause of that problem? Right? So besides measuring, I got to know a little bit more, which is ultimately to do something about it. It's not just the numbers, it's etiology, it's risk factors. Ultimately, we look at interventions. We look at evaluations of those interventions. What works to make sure that problem goes away, that we get a better hold of that problem? And then finally, it's implementation, right? The concept of how do we do this, not just for the group that we were studying, but in essence for the whole population, the issue of policies within public health. So let's look at the example of skin cancer, right? Public health burden of skin cancer. We don't really have great surveillance systems for this. We have decent surveillance systems for melanoma, the most severe form of skin cancer. When it comes to basal cell cancers, squamous cell cancers, less vibrant, but nearly 5 million cases treated every year in the United States. About 74,000 melanomas diagnosed in 2015 with almost 10,000 deaths. Melanoma is now the second most common cancer in women in their 20s. Canada, for example, has 6,800 cases, 1,150 deaths. So this is not just a U.S. problem. When you look at our neighbors to the north, it exists there as well. And once again, not a perfect surveillance system that cancer registries really aren't picking up on all the skin cancers that are out there. When we look at trends of incidence, 1973 to 2011, you look at male and female, and this is the annual percent change, the APC. Look at males and females and both together. In essence, we've seen a trend upward. So our surveillance systems are saying there is a problem out there. It also seems to be increasing. Now, there's many reasons for this increase. Part of it is maybe a greater awareness on our part. Part of it may be that dermatologists are biopsying more. But the reality is that in this surveillance system, however, what we're seeing is a reaction. And that reaction is we're picking up more of these cases. Age distribution of melanoma, once again, for the most part, the longer you're alive, the larger chance you have of getting melanoma. Economic burden of skin cancer. When we look at surveillance, oftentimes from the epidemiological perspective, what do we look at? We look at prevalence, we look at incidence, we look at raw numbers. It's become much more popular lately is to look at economic ramifications of diseases as well. And we as physicians tend to say, oh, you know, it's really not about these dollar figures. Well, it may not be for us about the dollar figures. When we talk about the political side of the house, and let me assure you that public health is politics. Right? When we're talking about ramifications of coming up with recommendations for a population, when you're dealing with issues of either a government entity at the state, local, or federal level, even when you talk about organized medicine coming up with recommendations, that is political. It deals with policies. It deals with ramifications. When we're dealing with policies, oftentimes the political side of the house, yeah, they care a little bit about our numbers. The incidence and prevalence numbers, sometimes we bore them with our, PowerPoint slides. But I'll be honest with you, after 28 years in Washington, D.C., a lot of it is about the money, right? How much are we spending? What are we doing? Is there a way to curtail those costs? And again, it may kind of, dismay us a little bit. What do you mean? We're talking about lives here. Putting things into perspective, the money argument hopefully doesn't overwhelm what we're trying to do, but is an important ally in all this. So nearly 5 million people are treated for skin cancer each year, cost of $8.1 billion. I realize in the federal government, all of my 28 years in the federal government, once you change an M for a B, from million to billion, people start taking notice. Right? If you keep it at the M level, it's really not that important. So in this case, you also look at the fact that the annual cost of skin cancer treatment has increased 126%. So the trending of this surveillance shows you that this is an important public health issue. We look at risk factors. Well, we know skin type plays a key role in all this, right? So you look at the white non-Hispanic population compared to the black population, the Asian Pacific Islanders, the American Indian, Alaska Natives, the Hispanic population. What we see is that there is a correlation here, right? The correlation is lighter skin puts you at higher risk. So that answer begins to answer the risk factor component of this. But also it brings into mind, right, the idea that it's not just about your skin type, right? A light skin color, whoa, that woke you up, didn't it? I'm sorry, I tend to be a walker, as you can tell. Let me bring it back down? Thank you, Jason. I'm yelling too much, am I? Okay. So anyhow, so part of this is it's not just about skin type. It's also about our exposure. And we begin looking at the idea of what do we know about the pathophysiology, about the etiology of skin cancer? Well, it's ultraviolet radiation related. And now we start looking at milestones of this. And really, there was incredible headway from a policy perspective in the 21st century. 2002, a national toxicology program here in the United States. 10th report on carcinogens listed broad spectrum ultraviolet radiation. Notice both from sun as well as artificial sources. They listed them as known causes of human cancer. Now, we look back at this and say, well, yeah, that's obvious. This is landmark, right? It's as landmark as the 1964 Surgeon General's report that came out, the first ever on smoking and health, that said this can cause lung cancer in men. And the world began changing after that vis-a-vis our approach to tobacco. I was relating last night at dinner that is a major public health advancement, right? A half century of work on tobacco, right? And you as a pulmonologist would appreciate this, right? The world has changed, right? 1964, 42% of our adult population were smokers, 42%. 50 years later, nationwide, we're down to about 15%. And yet we still have 480,000 people every year dying from smoking-related diseases. The problem is not gone, but we're trending in the right direction. So having this is, in fact, the beginnings of that realization, which is we need to understand and be able, from a public health perspective, to deal with this issue of ultraviolet radiation as a cause of human cancer. By 2003, WHO came out with artificial tanning beds, risks, and their guidance, which is now we're looking at not just the sun, but what people are doing, their decision-making, right? Do I look better in a tan or not? Do I pay money to go to a machine? Do I spend time at the beach exclusively for that tanning? Well, part of this is that education. Part of it is health literacy. Part of it is health communication, which is now, you got to realize that this artificial tanning sunbed and the sun are potentially problems. By 2005, the International Agency for Research on Cancer, IARC, puts out a risk of skin cancer and exposure to artificial ultraviolet light. By 2009, IARC lists UVR as a group 1 carcinogen, ultraviolet radiation carcinogenic to humans. That includes UVA, UVB, UVC, all the 3 spectrums of ultraviolet radiation, and includes ultraviolet emitting tanning devices. Right? So what we have is milestones that look from the surveillance, that now look at risk factors, that now start pointing away for what? That next step. And the next step is, what do we do from a policy perspective? We also look at the idea of health behaviors out there, right? The issue of what? Of, sunburns. 37% of Americans still report getting sunburned annually. Many reports frequent sunburns, right? The realization is we have the ability to begin a change in people's attitudes and perceptions. Now, one knows that behavior modification in public health is very difficult. Right? We've seen it from a smoking model, and part of the smoking model is what? An addiction to nicotine, so it becomes much more difficult. But we see it every day in terms of other public health issues, right? Are you eating well? Are you a healthy eater? Well, that's behavior modification. Do I really want, right, those greasy fries and that hamburger? Well, sometimes I do, right? And sometimes it's difficult to kind of say, well, let's modify that. Do I really want to monitor my salt intake for hypertension? Well, it tastes better perhaps that way. But in this case, what we're looking at is modifications of people's behaviors so that part of the messaging that goes out to them is about their health and about their decision making. And what we see in public health oftentimes is the success is not someone telling you, don't smoke, eat healthy, exercise, stay out of the sun. Right? I spent, again, 28 years in the feds wearing a uniform of the Public Health Service. It looked really flashy. And in uniform, a lot of times you say, I'm just giving you orders. No, America doesn't react to orders. I think we're in an age here and with other public health initiatives about to do what? Is we have a much more intelligent, much more aware population. Yes, the internet has opened up the world. You see it in your practices all the time. Patients come in with information about their diseases. They come in having self-diagnosed. And in the midst of all this, the reality, when it comes to these behavioral changes, is the job is a little bit different for us. Right? The job now needs to be that we provide further information, that we make sure the person understands what we're talking about, that we speak their language with health communication, that health literacy, distinct from health communication, is important in this endeavor. And that ultimately, you as an individual, you make the choice. I'm not telling you not to smoke, but I'm going to give you all the information necessary so that at the end of all this, you, through your own free will, and the beautiful democracy that we live in, basically say is, I'm not going to smoke because now I understand it. I'm now not going to, be out there sunbathing because I understand it. That really is sort of the game changer to a large extent of where we're heading in 21st century public health, which is education of our patients, allowing them the freedom to make those choices, monitoring those choices, but constantly providing that information. Because if we believe in science, if we're talking evidence-based, we need to make sure our patients understand that evidence as well. Sun protection. So we provide this whole idea of, okay, so you're out there. You're doing things. Are you protecting yourself? And you can see here the whole issue of shade, sunscreen, the wide brim hats, long sleeve shirts, long pants clothing, one or more protection measures. We have begun to change the world. And maybe it's in small increments, but if you go out to the beaches nowadays, you'll see most little kids are kind of covered up. Now, in my era, nobody covered me up. In my era, we knew a sunburn was bad, not because of ultraviolet radiation or the fact that I was putting myself at higher risk for skin cancer. It hurt, right? And maybe that's the motivation, is you don't want your kid to suffer. But the sense is the shade, the introduction of shade, even in beach and swimming pool areas, has changed. It's akin to how we've changed in terms of our attitude towards smoking. Right? Smoking is not illegal in this country. I know you have an issue here in Kentucky that continues. But overall, if I lit up a cigarette in here, right, we know that, first of all, I'd be breaking UofL rules, right? There'd be gnashing of teeth. When I wore the uniform and served as the acting U.S. Surgeon General, the ramifications of taking that single act would have probably led within hours of me being a former acting U.S. Surgeon General over lighting up a cigarette. So perceptions change, and to a large extent, we're beginning to see that change when it comes to sun protection as well. Now, the indoor tanning component, right, exposes users to intense UV radiation. More than 400,000 cases of skin cancer are estimated to be caused by indoor tanning. Roughly 6,200 melanomas. So now what you have is you have an industry out there. And I don't like to do direct comparisons saying, well, it's kind of like the smoking company, right, the tobacco companies. Tobacco companies were big. They're multi-billion, trillion-dollar entities. A lot of these are small business owners. But at the end of the day, as a public health person, I still have to acknowledge that what they're peddling is not really healthy. Right? What they're peddling is ultraviolet radiation. And the information they're sharing with their clients is incorrect information. Right? There's not a controlling mechanism there. And so what we're talking about here is that in essence is, from a policy perspective, knowing that there's an exposure out there, something has to be done about it, right? Estimated that over 11 million Americans tan indoors annually. Those numbers are coming down to some extent. 1.6 million teens are tanning on a regular basis. You look about U.S. high school students, right? The popular thing is what? I get a tan before I go for prom, right? It becomes part of a culture within those age groups, and yet we do see a leveling off. Now, when you look at regulatory public health vis-a-vis tanning beds, we see movement there as well. 2011, the United Kingdom comes up with a regulation that bans the use of UV tanning devices for those under 18. So action and a reaction to that, right? Information about UVR being a known carcinogen and a reaction saying, well, at least for those under 18, again, one can argue, well, why 18? Why not 21? Is it still a carcinogen if you're 18 and a half? Yeah, it really is. But in this case, at least we're setting up some parameters, and it's that first step. October of 2011, California becomes the first state to ban the use of UV tanning devices for those under 18. December of 2015, FDA puts out a proposed rule to restrict use of tanning beds to those 18 and over. Also puts out the proposal that the adult users would have to sign a risk acknowledgement if they're using those facilities so that they understand health communication, health literacy, what they're doing, and that warnings would be more prominent and there'd be other safety conditions put out there. So here's the good news. And here I got to say that coloration-wide, right, blue is good. So this is in 2009, right? First few states that come out there, Delaware, Texas, and Maine puts on some age restrictions. We have movement. We have activism. And here I can actually proudly say that part of that group of activists was our own profession as dermatologists, right? Derm started hanging out with state legislators. Derm started getting involved. And I'm not here just to praise dermatologists. I'm to remind you where we started here today, which is, in essence, we as physicians are not only examples for public health. How do we treat ourselves? What are we doing about our own health? But we also have this ability to become activists. And maybe some would say that that's actually part of our job. Right? It's not just sort of sticking out and saying, okay, I'm just a doctor. I'm here to diagnose and treat. That in fact, if we are to take on that duty, to take on the duty of health, and here I remind you of the definition of health per the World Health Organization. Health is complete. Important adjective, complete, not partial, complete. Physical, mental, and social well-being, and not merely the absence of disease or infirmity. If we are health care professionals, let's remind ourselves that it's all about health, and part of it is be activists. Right? Medical students, residents, realize, yeah, you're in the midst of your training, but don't forget that part of our goal in healthcare is to take care of that society, to remind those politicians that they have a duty regarding the health of people in their jurisdictions and in their land. So, 2009, 2012, 2014, 15, right? This is activism. This is movement where you can say, this whole idea of all of a sudden notice a new category appeared, under 18 ban for ultraviolet radiation and tanning beds. So we have known carcinogen, known reaction to this, and again, a lot of this pushed ahead by the activism of physicians. And what do we know, right? In states with multiple youth access restrictions, the odds of indoor tanning among teen girls were 42% less. So there is a reaction. There is a benefit. How this will now translate to the benefit of ultimately decreasing a health effect, i.e. pre-skin cancers or skin cancers, is still to be determined. But we're heading in the right direction. Policy. A lot has come into sort of mode about this group here, the U.S. Preventive Services Task Force. I got to remind you, this isn't a government entity. These aren't feds that are on this task force. It's our peers. It's fellow physicians. independent panel, non-federal experts in prevention, evidence-based medicine. They conduct scientific evidence reviews of the broad range of clinical preventive healthcare services, screening, counseling, preventive medications. They develop recommendations, something called recommendation statements. So this is the intro to this group, because this group oftentimes is severely criticized. Let's be honest, medicine, evidence-based medicine, we're not perfect. We're data-driven, but data keeps changing. And we can be critical of this group, but let's realize that this is a policy group. And this policy group back in 2016 basically concluded that the current evidence is insufficient to assess the balance of benefits and harms of visual skin examination by clinicians to screen for skin cancer in adults. And it's not to say that this doesn't work, but don't forget, recommendation based upon data. And when I look at this statement, a lot of our fellow dermatologists were kind of turned off to this. This is absurd because this is what dermatologists do. We look at the skin. It doesn't say stop doing this. What it says is we're actually more responsible than ever to gather the data of how effective this is. 2012, this recommendation continues, right? Recommends counseling of children, adolescents, and young adults aged 10 to 24 years who have fair skin about minimizing their exposure to ultraviolet radiation to reduce the risk of skin cancer. So again, when we look at recommendations of prevention from the U.S. Preventive Services Task Force, there is always controversy, and I'm not here to purely defend them, but it is a data-driven group. And that's where it's important for us to continue to do our screening, realizing that at some point, and the American Academy of Dermatology is an example of gathering this type of information so that we have more evidence. And one of the success stories when I was in those 18 months as the acting U.S. Surgeon General and my 5+ years as the Deputy U.S. Surgeon General was our ability to put out reports. So the team that I was in charge of, in conjunction with the CDC, put out the 50th anniversary report on smoking and health. It reminds us of the importance of smoking and tobacco use in this country even 50 years after Luther Terry's first report in 1964. But also, it allowed us to put out a report, a call to action on skin cancer prevention. And people will say, well, how did this all happen? So here's the truth behind the Office of the Surgeon General. Can the Surgeon General do things that the administration doesn't want you to do? Reality is, as a career guy, I'm an officer. I started as a young lieutenant. I finished up as a 2-star admiral. I take orders, even as a physician. And the bosses are the executive branch. So it's a very difficult world to sort of say, I am standing up and I'm doing X if the political side of the house doesn't want you to do X. On the other hand, how did this come to be? And again, this is all truth. The Assistant Secretary for Health happened to be a hematologist, oncologist, and dermatologist named Dr. Howard Koh. He's the boss of the Surgeon General. Acting Surgeon General was a family physician, preventive medicine, occupational medicine doc, and dermatologist. Notice what's happening here. So you get two people in positions of relative power who say, what can we do? And sometimes public health moves ahead because of interests of those individuals. Why do we choose skin cancer versus a million other things? It's all time and place and interests. And an administration that ultimately said, well, yeah, this can't be that controversial. Move ahead. And the beauty of this report was that, and I'll be the first to admit it, right? CDC was the main writer. Surgeon General office doesn't have the staffing to write these things. They spent about 1.5 years. There was nothing super novel in terms of new scientific information in this call to action. But what it did, and the major game changer was, it now said, right, that the Surgeon General finds this of importance. It's a trademark. It's a branding. It's the ability for public health to make a leap ahead based upon a cover to a report. And then what happens? Right? What happens then is that we're able to label this. For the usual news cycle in Washington, 48 hours that if anything is news, it actually took off, right? And there was this ability for us to ultimately provide further information to the American public, because the job of the Surgeon General is to take the best science available and provide it to the American public, translate where necessary. But that's the job, and we did that successfully in all this. The 5 strategic goals of that call to action was increase opportunities for sun protection in outdoor settings, provide individuals, notice back to your case, right? If I provide you with your information that you need to make informed, healthy choices about ultraviolet exposure, my goal is achieved. To promote policies that advance the national goal of preventing skin cancer, reduce harms from indoor tanning, and to strengthen the research, surveillance, monitoring, and evaluation related to skin cancer prevention. So the ability for the Surgeon General's office to be what oftentimes is called the bully pulpit, right? And I was always amazed, right, having spent 5 years in that office, that people no longer really are interested in the names of a Surgeon General. I was acting Surgeon General. Boris Lushniak is a tough name. Nobody's going to remember that name. Who's the last Surgeon General anybody really remembers in this room? C. Everett Koop, right? That's the last. Oddly enough, he's the one who signed my commissioning papers as I came in as a young lieutenant. Years later, I always have my commissioning papers on my wall because I'm proud of them, signed by C. Everett Koop, the Lion of Surgeons General. He signed them on July 4th, 1988. Years later, when I got to know him, I'd say, Dr. Koop, you signed my commissioning papers on July 4th. You must have been the only Fed at work that day. It's the 4th of July. Everybody's watching fireworks. He'd always turn to me and goes, Boris, frankly, I don't remember signing those papers. It always made me feel good. But the issue here is that it still remains a bully pulpit. We saw that with the release of the 50th anniversary report. The press likes this idea that the Surgeon General says something. And certainly when it came to skin cancer, this was the first ever report dealing with skin cancer. And what we saw then was this media coverage. And I was warned, right? This was bad timing to release this report. We wanted to release it in May. I talked a little bit about this at dinner last night. We ran into some obstacles with the political side of the house. It was released in July, and my public relations people said, this is not going to fly, right? It's summertime, middle of summer, nobody's really interested. Well, look what a single report with a single cover saying Surgeon Generals did. 2,000 plus reports were written or broadcast. Television programs led the coverage. Total publicity value, $12.8 million off of a single report. Cumulative reach of coverage, nearly 1 billion people worldwide. The social media component, the thunderclap concept, all this idea of pushing information out. Why? Because we repackaged a public health message. We repackaged those policies. We put a new cover on it and said, world, begin to listen yet again. And that's part of the success story in public health is we have to keep messaging. We have to keep moving ahead, hopefully with these types of successes. Now I'm going to make my switch into other public health issues. So we talked about the policy component. Since this is a Durham lecture, I'm going to now finish up with public health issues of, let's call it, a more extreme scenario. And this is part of my life. For 6 or 7 years, I was the assistant commissioner at the Food and Drug Administration for counterterrorism policy, right? And the concept here was, how do we make sure that we have all this protection out there, whether in the form of vaccines, medical countermeasures, et cetera, to protect America's public? I'm going to remind you the definition of bioterrorism: intentional or threatened use of viruses, bacteria, fungi, or toxins from living organisms to produce death or disease in humans, animals, or plants. Notice we always emphasize the human component of this. Animals and plants are a key component as well. One can understand that the devastation of putting out a bioagent that destroys crops or livestock can have its ramifications. We obviously, from a human health perspective, will emphasize the human component of this. This is my not-so-happy slide. And this is just to remind you that there's always bad things, bad potentials out there. The issue of this slide really is that notice potential impact on one axis, probability and likelihood on another axis. Even though we have all this situation going on with North Korea right now, there's a lot of fear, a lot of, reaction to this. Nuclear weapon, potential impact, incredibly devastating. In most circumstances, the likelihood is relatively low. But notice the other side of the curve, of the U-shaped curve, right? What we have is bioagents. And bioagents, probability, likelihood, it's actually relatively easy. We saw that in 2001 with the anthrax attack. And the devastation of a bioagent is potentially big. So, bioagents of highest concern, right? This is listed by the CDC, old terminology, as the Category A agents. What do we need to know about? Anthrax, smallpox, plague, tularemia, and the viral hemorrhagic fevers. Botulism also is included in that group. Notice that of these, the ones denoted in yellow may not have primary, some do primary, and in many cases secondary, cutaneous manifestations. So from the derm perspective of things, right, we as dermatologists need to know about it, but you as clinicians, again, fill in your area of specialty. These are things you want to be reminded of every so often, right? Because if an ER scenario, a patient scenario, if people come in looking like they have something weird, you have to be ready to react. And part of it is you involve public health authorities. If it's in your differential, it's important that you have that reactive mechanism out there. So just to remind you on anthrax, a zoonotic disease, we see it in animals, follows ingestion of spores in soil. There's 3 clinical forms: cutaneous, inhalational, GI. You can see the gram-positive spore-forming bacillus on this slide. Cutaneous anthrax is the form most commonly encountered in naturally occurring cases. Exposure to these spores, incubation period of 1 to 12 days. It's an occupational illness. We don't see it in the United States very often, but worldwide, people who work in soils, people who work with animal skins, will get cases of anthrax. The lesions shown here, day 4, day 6, day 10. The word anthrax comes from the Greek term anthracis, meaning black, the black eschar. Certainly, if you see a lesion on your board exams that has a black eschar, part of your differential is anthrax, but there's also other diseases that have the black eschar as well. What do we know from a BT, bioterrorism scenario, is 2001, right? And this came on the cusp of a world that was going a little nutsy at that point, right? Because what happened right before this was 9/11. So at that time, I was stationed here at the National Institute for Occupational Safety and Health. We got sent to the World Trade Center site to be responders there, dealing with occupational environmental issues. I come home back to Cincinnati for a few days, and then I'm sent out to Washington to work the anthrax cases. And notice, after all that hype, what was the final resolution? 22 cases of anthrax. 11 inhalational, 11 cutaneous. 5 deaths, all were inhalational anthrax. 20 were exposed to work sites where there was contaminated mail processed or received. Ramifications was post-exposure chemoprophylaxis for 32,000, and a world that was changed. Right? Do you remember your mail back then? Do you remember what was going on with sort of the uncertainty in our world? Do you remember patients coming in saying, "Doc, I think I have anthrax"? But when you look at it, and it's not to sort of say that this isn't an incredible impact. 22 cases and 5 deaths is a bad thing. But even this little bit, right, started changing the way we look at the bioagents. Cutaneous anthrax, in terms of its treatment and protocol for cases associated, it all boils down to Cipro or Doxy, right? Know your dosing, but that'll all come to be. We have a vaccine for anthrax. It's called Anthrax Vaccine Absorb. Induces immunity to protective antigens. It's a 6-dose series. Most of it was given to the U.S. military when we did have this hype. There's some controversy associated with this in terms of potential side effects, but it has been studied by the Institute of Medicine, now the National Academies, approved by the FDA, and so it's a clean vaccine with some tainted reputation. Supplies are limited. You can't get the vaccine. If we had an issue, we would then issue the vaccine, right? Right now, in some cases, first responders, laboratorians are still getting the vaccine. Switch over to smallpox. To be brief here, smallpox an incredible public health achievement. Notice the timeline here, right? Goes back at least 10,000 BC, Northeast Africa, spread to India and China, spread throughout Europe in the 5th century, the New World in the 1400s. Right? The Chinese began noticing that if you had smallpox, that you didn't have recurrence of smallpox. Right? This was the beginning of sort of this immunology, if you will. They started doing these procedures, right? From the Latin inoculare, meaning to graft. You would take a smallpox lesion from a patient and actually graft it into a patient without smallpox. And the idea was, I'm going to give you a mild case so that you will be immune. George Washington, 1777, told many of his troops to be inoculated. Jenner's cowpox vaccine in 96, the last U.S. case in 49. By 1977, the last natural case. This is public health working together. It was countries beyond the Iron Curtain in the 40s and 50s working through the World Health Organization with the countries of the West and basically dismantling, right? Taking care of a whole virus that used to be incredibly devastating. By 1980, WHO declared smallpox eradicated. Virus now remains on this planet in just 2 locations, at the laboratory down at CDC in Atlanta and the laboratory in Russia. And every 10 years, the World Health Assembly gathers to vote. Do we destroy the last vestiges of this virus or not? Thus far, the votes have always come in with, let's keep it a little longer, just so we can study it a little bit more. And we've done a great job in eradicating mammals, right? The dodo bird no longer exists in our society. That's a travesty. This is the first time we've eradicated a virus, and that's actually a good thing. Clinical smallpox, incubation period 7 to 17 days. During that period, it's non-infectious. A prodrome lasts 2 to 4 days, really, really high fevers. And an anthem appears, right? Small red macules and papules on the tongue and mouth, which can ulcerate. At that point, you're infectious. An exanthem appears later on, as shown in that cartoon, a centrifugal, face, arms, legs, hands, feet, and a progression of those lesions, macule, papule, vesicle, pustules, and crust. So progression over a 28-day course from those macules to the crusts can leave these long-term depressed scars. The big issue when we did have a smallpox heightened awareness, and in fact we started redoing smallpox vaccination because there was a fear that it was going to be used as a bioterrorism agent, was comparison with chickenpox. You can see the comparisons here, right? One central, varicella, distribution is centripetal or concave. The evolution of lesions is asynchronous. In both cases, the lesions crossed over. So in terms of lab testing for differential diagnosis, EM, direct fluorescent antibody, PCR, Zank smear, report obviously to state health departments immediately. Now we do have a vaccination for this, right? The word vaccination comes from the word vaxus, which means cow. In fact, work had been done beforehand. Benjamin Jesty, back in 1774, used material from cow udders to stop an outbreak in his English village. But all the fame goes to Jenner, who used material from cowpox, as shown here. The difference between the two, and this is important for the young people in the audience, was Jenner published. Jesty didn't. Who gets the credit and the stamps and all the recognition? The person who published. Remember that. Of course, HIPAA compliance, I had to put that in. Scarification technique is still what we use for this. It's really kind of an older way of doing things, but it's still effective. It's a little drop of the vaccine in between a double-pronged needle, and you tap the skin. Not too deep and not too superficial. This is my arm in the day when we were getting vaccinated at the CDC. Day 3, day 6, day 9, day 12, 17, and 19. This is a live virus with its ramifications. So you can have localized skin reactions to the vaccine, robust primary reactions, auto-inoculation, right? You touch your eye, contact transmission, ocular vaccinia. You also can have systemic symptoms. Generalized vaccinia, where the live virus spreads throughout your body, Stevens-Johnson syndrome, progressive necrosis, or eczema vaccinatum, which is localized or systemic dissemination, especially seen in eczema or atopics. We don't have an active smallpox vaccine program right now. There had been one in the last decade, especially in the military going on deployments. And so I'm introducing this just as an awareness that if this were to happen, be aware that this vaccine is a live vaccine. When we looked at it back in 2002, 2003, in the height of that, we had almost 500,000 troops vaccinated. The complications were few in number: autoinoculation, the generalized vaccinia, and the others as listed here. New things that came upon in the last vaccine campaign, most of concern was the cardiac, was cases of acute myopericarditis that had come up as a consequence of the vaccine program. I mentioned the MMWR, so in 2015, there's new guidance for smallpox vaccine. So although it sounds like this is a thing of the past, again, just a reminder that this still remains one of our concerns. There's a brand new vaccine, so this is late-breaking news. A non-replicating modified vaccinia was introduced in 2011. This is now out there. It's highly immunogenic and safe in mild to moderate atopics. So we use it in atopics, HIV, or other immunocompromised states. It is not a live virus, and so therefore it doesn't have quite the side effect profile of other vaccines. So that's sort of the late-breaking news. There's also new medications available for anthrax, for pulmonary anthrax, as well in terms of immunomodulating agents, working against the protective antigen as well. So in conclusion, right, we've taken the journey. And part of this journey was looking at derm examples, looking at our role in public health, looking at the core public health functions, and basically introducing the concept or reminding you of the importance of population health in everything we do. So I thank you so much for your attention here this morning, and I'm open for any questions at this point, Dr. Roman. Thank you.
Terrific, thank you. I'm going to ask you a question that may take you a little time to think about. And it relates to the concept of public health, how we use data. We've moved from a world where we were dependent on the decisions of gods and witchcraft to database. We moved to a stage where everything is so dependent on data that without it, you're paralyzed. To the point that when we are attacking truth, we have to do it by attacking data as opposed to addressing common sense.
Mm-hmm.
And so many of the things that I and you and others might think might be relevant to do in public health are sitting pending not just one piece of data, but decades of data. It happened with smoking, happened with skin, and so forth. Where is that threshold where a democratic society can make decisions for the benefit of its people, understanding that there may not be the best data out there? Now, I'll give you an example. I doubt there were many randomized, double-blind clinical trials for the use of seatbelts. I mean, nobody sat down with 100 people, let them to drive at 100 miles per hour. You would see them, you would not. We'll crash them and see what happens.
Mm-hmm.
But there was common sense.
Well, I think, there's several answers to your whole approach. I think certainly in medicine, what we have to do is, and I go back to that definition of public health, but also what we think of as medicine. Medicine is both an art and a science. And I think what we have to be able to do is we become scientists where necessary, which is data-driven, but the art still continues, right? The idea of kind of saying, what am I doing best for my patient, or what am I doing best for my population, that we would strive to have that data to be able to prove it. But ultimately, many public health measures were taken strictly from the perspective of not data-driven, but what made common sense. The problem is the world has changed since the time period of the seatbelts. And I'll take you back to that era, because the seatbelt issue was what? Was a reaction to morbidity and mortality in a motor vehicle. The feds basically said is, we think that there's an issue of, restraining that body and the moving. It didn't, it made sense from a physics component, The industry, however, said, we don't want to do this, right? It wasn't a no-brainer, right? Because the industry said two things. Industry said, I put seatbelts in this vehicle, the price is going to go up, and you're going to destroy my industry. And second thing is people aren't going to use it anyhow, right? So what we saw through that was an intervention, you're right, not data-driven, that made sense from a art perspective, that ultimately data was gathered after the fact. And I think what we have to be able to acknowledge is sometimes we need to push ahead with the recommendations and say we will gather data and readjust as necessary. So when it comes to the common sense things, I think that's the approach that needs to be taken. We live in a different world, however, than the 40s and 50s when we were doing that. The other part of the story on seatbelts was the only reason the industry actually ultimately succumbed was because the feds promised to them, and in essence it was a handshake agreement. Let me tell you to put in the seatbelts, and I'll never bother you again. Well, we know what cars now are, right? They're safer than ever, and the industry has just complied with the idea that now safety measures is a selling point, which wasn't back then. So the culture has changed. The issue that I see in terms of data-driven policy and data-driven decision-making in public health is sometimes we lose total control, and sometimes it's in essence the legal side of the house that makes us provide that data. And I'll provide an example. A few years ago, the Food and Drug Administration has brand new authorities over tobacco products, has a brand new center for tobacco products. They came up with a bunch of new regulations from a public health perspective that made sense. The industry didn't like these recommendations. The industry sued, and what did the judge say? Judge said, it makes sense to me, but FDA, go back to the drawing board because I need data to make a legal decision here. So it's not just science, it's the legal component where we do have a world that fights back. You know, there's a lot of gray zones out there, but that's a great question.
Questions, comments?
Yes?
About sun exposure and melanoma. So, we had a lecture around a few months ago about vitamin D. And so, someone who's very light complected, is 10 minutes of direct sunlight without any protection still ill-advisable, or, do you have any guidelines where you tell people?
Yeah, so in our call to action, I mean, that was always the big thing, right? And there's still a lot of controversy out there saying that we, in fact, are increasing other cancers by the whole vitamin D effect thing. My sense is, first of all, none of us are perfect in the realm of putting on sunscreens, okay? So whether you want to or not, you're probably getting that 10 minutes on board anyhow, right? The second component is vitamin D comes from multiple sources. My sense is that we should also be thinking about supplementation through foods or through, popping a vitamin every so often. Ultimately, there is a risk-benefit analysis here, and the risk is we know ultraviolet radiation is a direct carcinogen. It's been documented as such. Limit your exposure. Whether it's 5 minutes or 10 minutes, is that enough? The vitamin D issue goes on because the believers that vitamin D is all important in terms of being an anti-carcinogen, the believers are still out there. They're not necessarily supported by a lot of good data at this point. So right now we're basically, sort of the protracted answer to you is, you're going to get that 10 minutes, I'll guarantee you, without even thinking about it. Yes?
One of your early slides showed the incidence of melanoma by age and sex.
Mm-hmm. Well, again, I think it boils down to cumulative exposure for ultraviolet radiation, right? What we're seeing is the ramifications of a population that was never warned, right? So the reality is that if you look at some of the risk factors, which includes multiple, sunburns in one's lifetime, especially in youth, as being that modification or that risk factor, is we now are dealing with the ramifications of a society that the burns was not an issue, right? I think it was a lack of awareness in that population. So it's all risk related to exposure, cumulative exposure.
One last comment or question. If not, there's one there.
Yeah.
For the information of scientists bring out to the public, what is one outstanding
Well, I think the issue is, and this was a very common question when I was, in my previous position in the Office of Surgeon General, which is ultimately everybody wants to know is what's your priority in public health? And what you have to say is that, there are multiple priorities, right? The reality is right now, and our world keeps changing, right? The opioid issue is an example, right? 60,000 deaths a year now for opioid use, right? That becomes an issue right now. Now, 60,000 versus 480,000 tobacco-related deaths. And the reality is we are reactionary in public health. That's not a bad thing, because in essence, you need to react if the political side of the House says you need to react. And I'm not saying the 60,000 is less than 480,000, although I kind of am, right? So the issue is that I think in public health, what you have to be able to do is, there's two components to it, is you need to be battling on multiple fronts against multiple issues that exist out there. Is poverty a public health issue? Yeah. Is underemployment or not unemployment a public health issue? It really is. Is access to health care a public health issue? So those are priorities as well. So you have to function on multiple playing fields. The next component is, and this is critical to anybody in public health, is you need to be an optimist, right? If you look at the data, if you look at the slowness of response, and you're a pessimist, you're going to fail, right? You're going to fail. And the way I maintain my optimism, I didn't show the slide here today, but on my office board, right, throughout my whole career since the year 2000, are the 10 major accomplishments in public health in the 20th century. And what I see there are 10 things that changed the world, right? And amongst them are motor vehicle safety on that top 10. In 1900, we didn't even have cars. By 1999, everybody had one. It changed our lives. But we also had to react to the fact that it was killing people. Immunizations, vaccinations, between 1900 and 1999, the world changed, right? So when you look at this, the accomplishments are there, right? And whenever I give my tobacco talk, I talk about the accomplishments for the 21st century. In the 20th century, it was a simple thing. It was recognition. Notice the key word, recognition of tobacco as a health hazard. In the 21st century, the word has to change. It has to be elimination. So optimism. Is this a good thing or a bad thing? Yeah, I'm being optimistic here, but yeah.
So we have a tradition here to give our guest speakers a Louisville slugger.
Wow.
But particularly only for people who've been effective at delivering their message. But also for people who wander around the theater, which is actually pretty cool. So, but you brought to us a whole concept of public health and you blended it with the delivery of medicine as well as engagement and activism. And I think that was terrific. And in case you don't have data but you want someone to do something, this is for you, Boris.
Wow.
University of Louisville, November 30th, 2000.
Well, thank you so much. This is so great.
Thank you.
Really appreciate it.
You guys have a good Thursday.
Great. Thank you much. Wow. And we're big baseball fans, too. So this is
That's
great.
correct.
A Louisville slugger. Thank you much.
Excellent. Thank you. That was terrific. That was wonderful. Don't step down.
Okay.